Hello, my name is Dr. Ben Michael. I'm a reader and director of the Infection Neuroscience Lab, as well as an MRC clinician scientist, honorary consultant neurologist, and most importantly, vice chair of the Encephalitis Society's scientific advisory panel. And it's great to talk to you today about viral encephalitis. So, encephalitis is inflammation of the brain, and it's caused by broadly three different processes. The first is infections. The second is autoimmune disease, where we have an antibody directed against the brain. And then the third, variably between 10 and 50% of patients, depending on the study, we never find either a bug or an antibody. But the focus of our interest today is going to be on viral infection. Before I move on to talking about viral encephalitis, it's important just very briefly to highlight that it's not just viruses that can cause encephalitis, although they're one of the most common and important causes. We can also get encephalitis due to infection with bacteria, with fungi, and even with amoeba. A lot of what I'll be drawing on is advice that we published a decade ago now on the UK guideline for the management of encephalitis, which is currently under review. And also some parallel work that we did with the Encephalitis Society and with colleagues in intensive care and in allied health professionals such as nursing, so that we can help disseminate best practice management. The most up-to-date review on the topic is the paper that we published with Arun and colleagues in The Lancet a couple of years ago. And this is the diagnostic algorithm that we tend to focus on, which can make the diagnosis and management of encephalitis seem relatively straightforward and relatively linear. But of course, that's not the case when we think about all the different causes of viral encephalitis worldwide, which include Togaviridae, Flaviviridae, Bunyaviridae, Arenaviridae, Picornaviridae, and all these other different types of families of virus. But despite there being a lot of causes of viral encephalitis, the story of the presentation of the patient is often very similar. So it's typically a patient who presents with a fever or a febrile prodromal illness, like a cold-like illness, with or without symptoms affecting the gastrointestinal or genitourinary system, who then presents with some sort of alteration in their mental state, whether that's changes in their behaviour, personality, cognition or consciousness, with or without some other features like headache and something we call meningism, which is a sensitivity to bright lights, and neck stiffness, reflecting irritation and inflammation of the sac lining the outside of the brain. So when we have such a common presentation, but such a broad range of pathogens, the way we try and boil it down is to take the infectious diseases mantra, which is to ask ourselves, why did this person from this place at this time get this disease? So why this person? Are they particularly young or particularly old? Are they immunosuppressed? Have they had other strange infectious diseases? From this place, what does it tell us about the geography and pathogens circulating in that area? At this time, is there something about seasonality which helps point us towards a pathogen? And why this disease? Why specifically encephalitis? And one illustrative example of this is the zoonotic transmission of the Japanese encephalitis virus. So this is a virus which infects mosquitoes. Mosquitoes then infect pigs. And pigs, because they have a lot of virus, a high level of viremia for a long period of time, act as an amplification reservoir, providing an opportunity for multiple mosquitoes to bite them during that period and become infected. And then mosquitoes equally can bite wading birds, which of course, as do so many birds, travel large geographical regions. So this allows both amplification of the amount of virus in circulation and also spread of virus to new geographical regions. And humans, in fact, are what we call a dead-end host because they do not have a prolonged viremia, so they don't do amplification, and they don't tend to move around long enough whilst they're unwell, to really transmit the virus across geography. And because the virus primarily affects the central nervous system, there's not always virus in the blood to detect. And indeed, at the time of presentation with encephalitis, many patients with Japanese encephalitis virus, encephalitis, will actually not have detectable virus in their bloodstream or their spinal fluid at the time they present. But the reason these flaviviridae are important examples is that it tells us something about the patient in front of us and the importance of knowing where they've travelled to, because many of these viruses, like JE here shown in red, Murray Valley in green, St. Louis encephalitis in blue, and West Nile virus in yellow, are somewhat geographically restricted. And when we think about all these different viruses that can cause encephalitis, there's only really a handful where we have an effective vaccine. Particular global examples of success obviously being polio, and to some extent measles and mumps and influenza. More recently, Japanese encephalitis and more recently still tick-borne encephalitis have been huge examples of advances in our ability to vaccinate against encephalitis. But then there are some other viruses like varicella zoster, so the chickenpox and shingles virus, dengue, which is of global importance, which we have vaccines for, but of variable efficacy and with variable success of rollout programs. Here's an example of some of the rollout for the JE virus, again using that as an example, demonstrating that there are some areas, in fact 9 countries, accounting for 39% of cases where we have potential for a vaccine, but there is not a vaccine program, and there is ongoing transmission of the JE virus. But of course, these things change rapidly, and it's important that we work with our colleagues in the public health bodies. So that's the Centers for Disease Control and Prevention, or CDC in America, and the Health Security England, previously Public Health England in the UK. So we have up-to-date data on the transmission of viruses circulating in our area. Here a map showing the St. Louis encephalitis virus during that period by states in the US. Beyond where the patient's been, we also can get some other clues about potential causes of the encephalitis. One example here, you can see this man's back here. He's got this red rash, which is vesicular and tracks across the nerve pathways, what we call the dermatomes, which is consistent with the chickenpox virus, or varicella zoster. On the left at the top, you can see this person with the hallmark of what we call a target lesion, that central red bit, then normal skin, and then an outer red rim, which is classical for Borrelia burgdorferi or Lyme disease causing encephalitis. Beyond what we can see on the patient's skin, sometimes we get some clues from what we can see from the back of the patient's eyes, particularly if they've got inflammation of the retina or retinitis, which we often see with cytomegalovirus, again varicella zoster, sometimes with HSV, and a different appearance with toxoplasmosis. Particular importance because these are opportunistic infections occurring in people with an impaired immune system, such as with HIV here. When the patient comes in, we need to do some diagnostic tests early, particularly a lumbar puncture to sample their spinal fluid, an MRI scan of their brain, and some blood tests for their antibodies. It's routine practice now, and in line with the guidelines from 2012, to start empirical treatment with the antiviral drug acyclovir. And often in the early phases, this is started with antibiotics because until the cerebrospinal fluid results are back, it's not immediately clear whether it's a virus or a bacteria that's responsible. But one of the crucial things about the lumbar puncture is we know that in work that we've done in the UK and corroborated by work elsewhere, even in high-income settings, there's often delayed and absent testing of the spinal fluid, with delays in the lumbar puncture, and this often occurring in people with encephalitis more than those with meningitis, which is often more readily recognised. And the reason this is important is the longer we wait from symptom onset to performing the lumbar puncture, the less virus we often find in the spinal fluid, particularly if the antiviral drugs have been started, and the same is even more true for bacteria. When we look at the viruses, we typically do these tests for herpes simplex, so the cold sore virus, and the varicella zoster, the chickenpox virus, and also enteroviruses as they're common. Particular times we'll think about influenza or in people that have been inadequately vaccinated, think about measles and mumps, and then the travel history, particularly the arboviruses like JE that I've mentioned. If the DNA test for the antibody is negative, then the next thing we do is we actually look for antibodies to the virus, and we measure the antibody level in the spinal fluid and the antibody level in the blood, and this is now something that's offered by the UK government. And then we use something which compares the amount of protein in the blood and the spinal fluid relative to the amount of antibody in the blood and the spinal fluid to allow us to identify if there's not just virus present, because of course almost all of us will have some antibodies to common viruses like the cold sore virus, but crucially to identify if there's antibody being produced to the virus in the spinal fluid that's disproportionate to that we see in the blood. Whilst the most specific changes are those we see in the spinal fluid, we can also get some clues from the MRI scan. Here are some examples of, in A, you can see the very this is like you're looking up from the patient's feet up towards the base of the brain, so the left is on your right. So you can see here in A this bright white area, which is the bilateral but asymmetrical inflammation of HSV encephalitis or cold sore encephalitis. In B, you can see the actually very symmetrical and more well circumscribed areas of inflammation we see in the autoantibody encephalitides. And then here in C through F, you can see changes in the basal ganglia, these deep structures in the brain, which we see with the flaviviral encephalitides like Japanese encephalitis and dengue and West Nile that I've mentioned. There are some other typical changes here in G and H. You can see some inflammation. This is now looking sideways on in the brain at the brain stem, and you can see some inflammation here in H, which is due to the bug Listeria, often from unpasteurized dairy products. And then in I and J, you can see these inflammatory demyelinating conditions which can mimic encephalitis, including acute disseminated encephalomyelitis. But when we think about actually using MRI to help diagnose encephalitis, it's really important to think about how limited this is in so many parts of the world. And here's a map showing MRI units per million of the population for where we have data. And you can see in the global south, particularly in Africa and parts of Indonesia and Latin America, this is a real challenge with limited access to MRI scans. One of the other techniques we use to diagnose viral encephalitis is to measure the brain waves, and this is something called electroencephalography, or EEG. And it was originally thought that these spikes that you can see here on the EEG, which is sort of brainwave spikes, were actually telling us it was HSV encephalitis, but we now know actually these are very non-specific findings that can be seen in poor brain oxygenation, metabolic problems and other things. But the real role of EEG is really mainly in these sorts of conditions where we have a patient in front of us who is in a coma with a suspected brain infection, who's not waking up, and where we can see these subtle twitching movements, which can be fingertips of the face or of the distal limb, and then you can see that actually after we watch this patient for a little longer, they start to have this posturing change that we see, and this is consistent with someone that's having a seizure. So it's not the whole body shaking seizure one typically thinks of, but something called subtle motor status epilepticus, and even patients can be in non-convulsive status epilepticus, where really they're just in a coma and there's not much to say in the way of their body's movement. One study we published recently, we looked at everyone where a doctor had thought, over 3 years, a doctor had thought the patient might have this non-convulsive status epilepticus, or seizures causing a coma, basically. And of 358 requests, only 8 actually showed the condition. But of those, they were all patients with encephalitis, or the other smaller number was those with alcohol withdrawal seizures. So that really is a role for EEG in our patients in front of us who are confused and not waking up, with or without evidence of motor changes. So clearly, when it comes to management, if we find one of these acyclovir treatable viruses like HSV or VZV, so cold sore and chickenpox viruses respectively, we continue treatment with acyclovir and then we perform a lumbar puncture at the end of treatment, whether that's 14 or 21 days, depending on immune compromise, and to make sure we've cleared the virus before we stop the acyclovir. One of the big calls I get through the National Neurological Infectious Disease Advice Service is someone with a known cause of viral encephalitis who's not improving on acyclovir treatment or they're deteriorating. One option is that they've been undertreated, so we need to make sure we treat our patients for 14 to 21 days, repeat the lumbar puncture, make sure we've cleared the virus, and only stop the acyclovir once the virus has been cleared in 7-day cycles. Whilst mutations in the viruses are common, it's actually rare for them to be resistant to acyclovir in a way that's actually going to be clinically important. And of course, there are post-infectious phenomena such as post-HSV autoimmune encephalitis. The other two things we worry about are seizures and edema. So with regards to seizures, the mechanisms of what's actually causing the seizures is poorly understood. To what extent it's the virus, or is it the degree of the volume of brain involved, or is it the time to treatment, or something about the inflammatory response is unclear. And what's really important is there have been no randomized or quasi-randomized trials actually looking at using anti-seizure drugs, which we know are effective for seizures, in patients with encephalitis. We've just submitted a piece of work where we looked at patients, around about 500 patients from 2 UK cohorts, where we looked at all the factors that predict seizures at any time, and also those factors that predict seizures in people who are in hospital when they develop their seizures and could have been caught early. And the key things there were the antibody-mediated and the HSV patients were at highest risk. Also, the coma score at admission was strongly predictive of going on to have seizures, even if you hadn't had seizures at the time of presentation. And the EEG, or the brainwaves being abnormal, was also predictive. And we've developed a number of statistical models, which I won't go into, but it seems that when we developed this predictive tool, that when we apply it in a second cohort of patients, actually it was also very good at predicting seizure risk, and this is currently under review. And the reason this matters so much is because when we look at the patients who've had, firstly, no seizure at the beginning, seizure at any time is the next column, then an inpatient seizure, and then this prolonged seizure we call status epilepticus, the likelihood of a good outcome decreases the more people have had seizures, suggesting that if we can genuinely identify this group at high risk of seizures, then there is a window for an intervention where we can actually potentially start an anti-seizure medicine and improve patients' outcome. One of the other pieces of work we've been doing is we've been looking at the volume of brain swelling and whether that's due to the virus killing cells or whether it's due to swelling because of breakdown of the integrity of the blood-brain barrier. And we've been using this to see if we can improve our clinical model for predicting seizure risk. Because currently where we're at is if someone has viral encephalitis and they're getting so much brain swelling that the unhealthy diseased encephalitis portion of the brain is squashing the otherwise healthy portion of the brain, our main option actually is to use a surgical technique to remove the skull or a portion of the skull to allow the brain to swell or herniate out through that hole and then reinstall the skull. And we've been involved in several cases, including this young boy from our area who required this brain surgery to save his life. So, of course, brain surgery is a high-risk option. So the main question has been actually, is there a role for using an anti-inflammatory therapy? And this is variably used, but because it typically gets used in people who are at the most sick, it's hard to determine whether it really improves outcome. And I'm delighted that in these coming weeks, the randomized controlled trial of the use of a steroid called dexamethasone in HSV encephalitis will be concluding recruitment, and we hope to have results in these coming months and certainly by the end of the year to help direct the management of patients. And that's led by Prof. Tom Solomon here. But of course, the worry with using steroids is it might be a sledgehammer to crack a walnut. If we so suppress the immune system with steroids, do we mean that actually we're licensing uncontrolled viral replication? And really what we need is something more targeted. So one of the pieces of work that I did some years ago was looking in spinal fluid and blood of patients with encephalitis to look at what the immune response was. And I found that there was this particular balance between these inflammatory proteins called cytokines, and particularly the balance between a cytokine called interleukin-1 alpha and beta relative to the endogenous antagonists made by our own bodies was the strongest predictor of breakdown in the integrity of the blood-brain barrier, as measured by the amount of protein in the spinal fluid, the volume of swelling on the scan, the degree of coma of the patient, and their poor outcome. I then went on during some of my postdoctoral research in Boston in Professor Andy Luster's lab at Harvard to develop a model where we could study this in mice, where an anaesthetized mouse has a portion of their skull replaced with glass, and they're genetically engineered so that when we use lasers, we can actually stimulate different immune cells to fluoresce different colors. And here you can see that's a movie from the brain, the cortex of an anaesthetized mouse who's deeply asleep, and you can see these green immune cells traveling down the bloodstream. What I was able to show was that actually following infection with the cold sore virus, those immune cells migrate out of these blood vessels in the brain and start to crawl within the brain. And lastly, what I was able to show was to identify the specific protein that was calling these immune cells in. So if I used mice that were knockouts or genetically deficient for that receptor, or if I used an antibody that blocked that protein, whilst those immune cells were called towards the brain blood vessels, they were actually unable to get into the brain, and these mice were protected from encephalitis. And we have done some further work to identify how these immune cells cause damage to the blood-brain barrier. And here you can see on the top left, there is a little spurts of red, and that's the fluorescent tracker within the blood vessel leaking into the brain in response to the immune cells migration. And with one of my postdocs, Laura, we've done a lot of work looking at this and actually identified that there are aspects of brain cell damage and also aspects of the proteins on the surface of the virus which activate the immune cells of the brain, which are called microglia, to produce the same inflammatory mediators we'd seen in humans, and that this produces the protein which drives these immune cells into the brain. So moving beyond the things where we know what we're doing, there are, of course, as I mentioned, 10 to 50%, typically around a third of cases where we don't find a cause. And then we're in the tough situation where we have to start to think about whether there might be an immune process at play, even if we can't find a virus. And we have to think about taking the challenging decisions around discussing the pros and cons of starting immune therapy empirically. So I've talked about the viruses we know lots about. Of course, the eagle-eyed of you will have noticed that there's a particular virus which I haven't discussed yet, and that, of course, is the coronaviridae. And we'd had SARS first and then MERS, and now, of course, we've had SARS-CoV-2, which we're still responding to now. We've done lots of work in this space and identified that maybe 70 to 80% of people hospitalised with COVID have some sort of neurological symptoms. Maybe up to 10% have a neurological syndrome, like brain dysfunction, and maybe up to 1% can have a brain diagnosis, including encephalitis. And there's a range of ways this can affect the brain. It can again break down the integrity of the blood-brain barrier, particularly involving infecting the endothelium, or these the lining cells of blood vessels. It can produce these inflammatory cytokine proteins I talked about. In some, it seems to induce autoantibodies. and in some it seems to inflame the blood vessel and affect the clotting pathways. I was, very privileged to be at the helm of the UK's response to this, and we were the first country to get up and running really and publish our first 153 patients from a UK-wide surveillance study, which really was a collaborative effort. We involved, rather than universities, we involved all the professional neuroscience bodies in the UK, including the Royal College of Psychiatrists, the Association of British Neurologists, the British Association of Stroke Physicians, and many others. And due to their hard work, we were actually able to get up and running during the exponential phase of the pandemic. This allowed us to study lots of things, not least of all the early identification of the role of vascular problems like stroke, but increasingly over time, here in the dash and dotted line, relative to the light grey dashed hospital admissions, we saw that stroke notifications started to decline, but rather these altered mental status, that's AMS, cases which include encephalitis, seem to increase over time during each wave, suggesting there might be a different sort of mechanism involved. We then went on to look at really detailed clinical data on these patients, identifying that the stroke cases tended, or cerebrovascular as it is there on the graph, tended to present to hospital with their stroke at or around the time of their COVID symptoms, whereas inflammatory problems, like encephalitis, presented statistically significantly later, at an average of about 2 weeks after respiratory symptoms, suggesting that maybe it's direct viral replication that's important for strokes, but a virus-induced immune response that's important for encephalitis and other inflammatory conditions. And why this was really important was that about a quarter of patients presented with their brain complication after they'd recovered from their respiratory problems, and a further quarter actually presented with a brain problem that predated any respiratory symptoms. And these findings would go on to inform the WHO screening checklist for COVID. But whilst that's very straightforward in terms of different pathologies, we actually found that there were many patients who had these sort of overlapping syndromes. Maybe they have an inflammatory disorder that presented with a psychiatric presentation, or an inflammatory disorder that also presented with a stroke. And whilst these were less common, they were important because they were much more likely to require intensive care, ventilation, and had a worse outcome. We also worked with the paediatric counterpart to the Association of British Neurologists to identify less commonly, but nevertheless importantly, these overlapping syndromes in 52 children from across the UK, some who had a central inflammatory problem with a brain complication, and others with an isolated brain complication, suggesting that the inflammatory problems can be isolated to the brain or can be part of a more systemic process with brain and multi-organ inflammation. But there still remain a great many research questions which are unanswered, particularly what are the clinical characteristics and crucially the underlying disease mechanisms of these neurological complications of COVID, who is at risk and what are the medium-term sequelae. And that's why I'm delighted that we've been funded by the MRC and UKRI to run a £2.3 million study called the COVID Clinical Neuroscience Study, or COVID CNS, which has already recruited many hundreds of patients and through which we'll understand better these disease mechanisms which have implications not just for COVID, but for other ways that viruses can affect the brain directly and indirectly. I'll draw things to a close by saying that if there are cases you wish to discuss, please do contact the Neurological Infectious Disease Advice Service. It's largely UK based, but we'll help wherever we can around the world. And to conclude that, suspected acute encephalitis is a common emergency. Vaccination has a crucial role in both the prevention of disease, as we've seen with Japanese encephalitis virus, as we've seen with polio and measles and mumps, and as we're now seeing with SARS-CoV-2, and also has an important role when patients present in terms of identifying the likely pathogen. There are particular clinical clues given aspects about the patient's demography, travel, and some of their clinical features. Investigations are crucial, particularly CSF and neuroimaging, but timing of these is really important, as is working with our colleagues in our reference laboratories. Complications such as brain swelling requiring surgery or immunosuppression are huge complications that require further work, as does the emergent phenomena of pathogens like SARS-CoV-2, and that work is very much ongoing, so please do watch this space. It leaves me lastly only to thank the team of the Infection Neuroscience Lab, particularly Vicky and Naomi, the Programme Management team, all the research assistants and fellows, the postdocs, clinical research fellows, academic clinical lecturers, PhD students, and allied professionals working in the research space. Also to thank the team that do so much of the neurological education work on encephalitis in collaboration with the Encephalitis Society, and my NeuroPaces and NeuroAccess programs in Zambia and Mozambique, where there are huge burdens of encephalitis and related brain infections. Lastly, to thank you all for your time, and of course to the funders and the Encephalitis Society for this platform.